Integrative orthopedic acupuncture of the elbow, wrist, and hand, or upper extremity. Let's get to it. The history. The first thing you want to be able to identify is the age of the patient. If they're between the ages of 30 and 50, they tend to have lateral epicondylitis is one of the most common things that you'll see, which is an extremely common case to see in acupuncture practice. Most times, these conditions can resolve on their own within 1 or 2 years, but who wants to wait 1 or 2 years? And another condition based on age is a child complaining of elbow pain. What this usually can be is a come-along injury, which is a parent holding the child's hand and then tugging their child can sometimes free the radial head from a ligament that surrounds the radial head. So it's called a come-along injury, and it is a radial head dislocation. So of course the parent feels terrible when this happens, but it's something that can happen. So if you see a child who has an elbow injury, the first thing you think of is, was this from a mechanism where there was a strong pull on the arm? Also, because of age, you're going to see osteoarthritis of the fingers, and we'll get more into depth as to different areas of the fingers determine osteoarthritis, and we'll compare that to rheumatoid arthritis. Main complaint, repetitive stress injuries. What is the patient's occupation? Now, every day, plenty of patients are working on computers, the objects in front of them. So we talked a lot about it when it came to neck pathology, sometimes shoulder pathology, but also mostly wrist and hand pathology. How is this affecting their hands? How many hours a day are they on the computer? And oftentimes, when we have a runner that's running and hurts themselves, we can say, stop running. How often can you tell someone, stop typing on the computer? It's probably causing some repetitive stress injury. Not an easy thing to do. So that will tell us what the mechanism of injury is. Another type of injury, which is the diffuse injury, which is a fall on the outstretched hand injury, can lead to a carpal bone fracture or dislocation, which is often from the lunate, pain from with passive range of motion wrist flexion. So you can kind of dislocate, and sometimes you'll see a bump. So if you see a bump in the back of the wrist and it's from a mechanism of injury, it may be a carpal injury. Now, if there's a bump on the back of the wrist and there doesn't seem to be truly a mechanism of injury, that could be just a ganglion cyst, and we'll talk briefly about that at the end. What movements cause or relieve pain? Again, looking to see, is it from just maintaining certain positions for a length of time that causes the pain or causes the sensation to come on, or is it a specific type of movement? And when you know if it's a specific type of movement, you can use range of motion as an outcome measure. You can also try to figure out what joint is being affected. Any restricted ranges of motion, of course, will help to contribute to that as well. So the picture above me here is an olecranon bursitis. So knowing exactly where the pain is important. When it comes to elbow pathology, wrist and hand pathology, more likely than not, if you're palpating the area and you can reproduce the pain, it's probably coming from that area. Certainly we can have pain referral that comes from the neck or from the shoulder that refers into the elbow, wrist, and hand. But for the most part, if you're palpating in these areas, you're going to find where pain is. Whether you're palpating the lateral epicondyle, the medial epicondyle, or in this case, the olecranon area, this is a bursitis we're seeing here. The anatomical snuff box is another area that you can palpate to see if the person has a scaphoid injury in the hand. And I'm just going to show you another picture, because why not show you a really terrible picture of an olecranon bursitis. So this is the kind of times when you see a bursa getting really inflamed, really angry, and having nowhere to go but out because it's right over a bone. So sometimes you can see a presentation like this in the knee. But this is a really bad case of it. But to be honest, you'll see cases that can be somewhat close to this, and you'll know right away what it is. It looks terrible, it looks awful, and it's just the bursa is swollen in that area. What is the history of the condition? Determining whether it's acute, chronic, or acute from a chronic condition. When did the pain come on? What is the pain type? Does it radiate? Differentiate it between what is electrical, neurogenic versus somatic, which is musculoskeletal. You want to differentiate what type of pain is being produced, and which hand is dominant can sometimes help to determine if it's a repetitive stress injury. In inspection observation, the first thing we can look at is the carrying angle of the elbow. So normal will show you that degree, and I gave you some degrees in your notes that you should probably sort of understand and know. When someone has a cubital valgus, and think of it as the L coming out, it's usually greater than a 15-degree position of carrying angle, which is when the arm is to the side, and how many degrees of sort of deviation laterally do you see. When it's less than 5 or 10 degrees, it's a cubitus varus or a cubital varus. You don't see too many cubital varices. I mean, most people have a certain degree of valgus, but you will see a varus in some cases when there's elbow pathology. And certainly if there's an elbow fracture, the person will have a difficult time fully extending the elbow, or you might see a valgus or varus presentation. If there is an elbow injury, the common areas that you'll see swelling will be just on, this is the lateral section of the elbow, because you can notice that the radial head is there. And so in this particular triangle here, combining just the areas distal to the radial head, the lateral epicondyle, and the olecranon, this little triangle here, you want to compare this side to the other side in terms of what degree of swelling fills up this area. And that'll also tell you if there's a pathology in the elbow. Let's see. Here in the hand we have thenar wasting, and this could be from a carpal tunnel syndrome. I've seen a case of this where it was from a viral injury to the median nerve causing thenar wasting, or maybe it wasn't median nerve, maybe it was just the muscle itself. But a very peculiar case that, most of the time if you see this kind of thenar wasting, it's usually related to carpal tunnel. And how do you assess this? Well, if you put your hands together like this, you can kind of see, or you can't see, but you can kind of compare one's thenar muscles to each other, and then I can even go this way and compare my hyperthenars. So I'll sometimes have patients do this to see if there is wasting, if they do present with a carpal tunnel syndrome or some kind of pathology in the hand. Do we have any muscular wasting? That may not be so evident when you first look at it, but when you compare it to the normal side or the unaffected side, may become more evident. The dorsum of the hand, the anatomical snuff box, is an area that we will talk about a little bit when we talk about decraveins or tenosynovitis. We'll talk about ganglion cyst, osteoarthritis. What we have in picture A is the Herberdine nodes or Herberden's nodes when we see osteoarthritis of the hand. When we have in picture B here, we have the Bouchard nodes, and this is just one way to classify osteoarthritis. Typically, I just look at the fingers, and if there's nodules at either these the DIP or the PIP joints, then I'm looking to see if that's an osteoarthritic case. And some people have some fingers more affected than others, but this is osteoarthritis. What makes this different than rheumatoid arthritis, we know that osteoarthritis is sort of a wearing away of joint space, and maybe there's some kind of genetic component to it. But rheumatoid arthritis is an autoimmune disease. And what the patient tends to present with, they could present with a little bit of this, maybe a combination of osteo with rheumatoid, but you tend to see, of course, not as bad as this, but you tend to see something close to this, which is called ulnar drift of the metatarsophalangeal joints. And so right at the knuckles here, they'll have sort of ulnar drift of the fingers, and that's a little bit of the MCP, the metacarpal phalangeal joints. And that'll be more of a rheumatoid presentation. But if they come in and say, I have rheumatoid arthritis, and they have a nodule on the tip of their finger, maybe they do, but that's an osteoarthritis you tend to see there. So I'm going to give you a list of things that you could palpate, but specific areas that you can certainly go through this areas, but the big ones are medial and lateral epicondyle, the anatomical snuff box, and you're noting for any sort of areas that you can press, and I'm sure, that you can press and try to recreate the patient's pain. When we get into special testings, the first thing we talk about is range of motion, or in this case, active range of motion. So you can see this little picture here. It talks about the different types of flexions, extensions, pronations, supination, those kinds of things. When it comes to flexion extension, I often have the patient sort of extend their arms out and have them flex and extend both wrists. So have them maybe do an extension of the wrist, and I'll put the hands together to see if one seems to be extended better than the other, and I'll have them flex the wrist to see if there's some restricted range of motion that's occurring. And it could be just from swelling, but it helps you to determine, again, outcome measure, is there a restriction that you can look for? What you see in the picture is the normal degrees flexion extension for the elbow, and then supination pronation for the hand. And supination pronation is other things that you can see too if you can compare one side to the other. Getting into special testing, this isn't a great picture. Watch the videos. The video is a little bit better. Looking at valgus and varus ligament instability, and that is just stressing the medial and lateral collateral ligaments of the elbow to see if they're disrupted. So I would typically test those if I thought there was a laxity issue or a hypermobility issue of the elbow, or if I knew there was a mechanism of injury that I wanted to test to see the integrity of the ligament. But check out the video. The video shows it a little bit better. This guy, you're seeing that his right hand is doing a valgus stress test on the left, and then on the right picture, his left hand is doing a varus stress test. But it's kind of confusing because he changed positions, so I don't know. It kind of screws up in my head when I look at it that way. When it comes to muscle and tendon pathology, you're going to want to know these types of tests, and they're named because why make the name easy? We might as well just give you a difficult name. And when we talk about lateral epicondylitis, I know my head is blocking one of the pictures, but it is in your notes. The first test I like to do is the extensor digitorum one. Now, the reason why I do that test, because it's relatively mild. If I jump to the Cozen test, I'm going to create a lot of pain with that test. So I start off with the extensor digitorum test, which is usually just extension of the extensor digitorum and putting very gentle pressure down on the middle finger to see if I can recreate pain at the epicondyle. If I can do that, I don't need to go to the Cozen test. I can probably go to the Mills test just to get a second test to see how it is. But the easiest test or the nicest test is the extensor digitorum, and then it's the Mills, and then it's the nuclear version, which is the Cozen test. So if you're really not sure what an elbow is kind of doing or where it's coming, where the pain's coming from, you can ultimately do a Cozen test to tell for sure. And the way I broke these down was, think of it in terms of whether the person is contracting or resisting you, or whether you're stretching the tissues that could be affected. So in the Cozen test, the patient's going to be resisting extension. When we jump to the Mills test, we just put the patient in deflection to stretch the structures that attach to the lateral epicondyle to see if they're affected in some way. When it comes to medial epicondylitis, and don't forget, epicondylitis doesn't only tell us that there's inflammation. There's probably a pathology of a tendon going on over there, so it's more like a tendinosis that's occurring at the epicondyle, but this term is still used quite a bit, and we'll talk more about the pathology. But there's the medial epicondylis test as well, which is again just stretching the flexors, and so it's putting the hand into extension, and don't forget to involve the fingers with the test so that you can get a good representation of the test. When we get to neurological dysfunction, we're looking to see if the median nerve, as the brachial nerve comes down into the arm, what happens is at some point the medial nerve the median nerve will actually go in between the pronator teres muscles, and I'll show you another picture of that in just a second. The elbow flexion test, however, is to see if your ulnar nerve is getting compact in its cubital space. So by kind of doing this kind of motion, and I'll even sometimes cause the elbow to kind of create more flexion and more extension at the wrist. I'm trying to see if I can cause an impingement of that nerve in that little cubital tunnel. And in that tunnel, if there is a problem there, surgery usually is to take that nerve out of the tunnel and put it outside the tunnel. So when they do a surgery like a Tommy John surgery, which is repair of the medial epicondyle ligament or the medial collateral ligament, they'll just take that nerve out so that it doesn't cause trouble down the line. Sometimes they do that, sometimes they don't. When it comes to the pronator teres test, this is a little bit more challenging to do, and I'll have to show you in class specifically how to do it. Certainly watch the video. But what we're looking for is we're trying to see if when we contract the pronator muscle, if the nerve that is going in between the muscle bellies is being restricted in producing median nerve innervation problems in the hand. And typically the median nerve will be affecting the thumb, the index, the ring, and usually, thumb, the index, the middle finger, and usually half of the ring finger. So if there's numbness and tingling along those fingers, then we may have a median nerve involvement. So I'll ask you a question as to whether, think about what nerve root would be also these two fingers and the middle finger. So I've got to think about the nerve root too. We'll get to that. So another picture will show that the median nerve can sort of go in between the two heads of the pronator, and sometimes it'll actually pierce between one of the pronator heads, and often another time you might find that the nerve is deep to both muscles. And so you can understand that if it's piercing through the pronator teres, the person might be more apt to have a pronator teres median nerve impingement problem. And so we're kind of coming down the neck, into the shoulder, into the elbow now, ultimately into the wrist to talk about carpal tunnel syndrome, but we have to tease out these areas to determine where the pathology lies. This test, the Finkelstein test, is a test if someone has de Quervain's or tenosynovitis of some tendons in the wrist. And then, of course, we have the carpal tunnel test. The picture above me here is the Phelan test. That's the better test that's often used. I'm going to show you also the carpal compression test, when you just compress the carpal tunnel to see if you can recreate median nerve impingement. And what they'll do in a doctor's office is often do an EMG, which typically involves inserting needles, which hurts a lot for most patients, into the different muscles, and then testing to see if there's a nerve conduction problem, where it's coming from. Is it coming from this area of impingement? Is it coming from the cervical nerve root? They're trying to tease it out doing an EMG test. There's also surface EMG, but that's to determine sometimes different things. It doesn't hurt as much, certainly. Diagnostic test, and you're going to get a lot of information from doing X-ray in the elbow and in the hand and the wrist, because more often than not you're looking for structural issues. If it comes to sort of nerve issues and other things, I'm thinking ultrasound, MRI would certainly be used, but you don't see it as often. Mostly it's just getting an X-ray. When it comes to the elbow, you're looking to see if something's fractured or there's a problem in the elbow. When we get the diagnosis, prognosis, elbows are easier to treat than the wrist and hands, because if you think about the low vessels, the main meridians don't necessarily penetrate the joints, and so we have a lot more joints in our upper extremity, elbow, and of course the wrist and hand, than we have in other areas, and so it's more apt for stagnation to occur. As far as prognosis goes, it's a little bit difficult to really determine how something's going to react. You have source and low point combinations in your notes, so look those over. I'm not going to spend much time on those. Let's get right into pathology. Lateral epicondyle. So it'd be lateral epicondylopathy. I don't know. It's condylitis, often called tennis elbow, and it is an irritation of the attachment of the common extensor. It's a common extensor tendon, but there are multiple extensors that kind of contribute to that common extensor tendon, and it inserts right on the bone. Now, what happens is, if there's lots of forces occurring there, you can start to develop microscopic or micro tears of the tissue. Now, in this picture over here, I think you're seeing a little red dot on the muscle or on the tendinous tissue that is causing where the micro tearing is occurring. Oftentimes, it's a little bit closer to the epicondyle, and if you palpate in this area, sometimes you can feel a little rice grain or a portion of the tendon that is inflamed or maybe even torn. You can put your finger right on the spot of pain, and I'm going to show you a technique to go in there and do osteoacupuncture, which is needling at this site, causing a little irritation to produce an immune reaction to get that tissue to start to heal, because this is an area that gets a poor blood supply. What I have in here as well is large intestine 4, but Ling Gu or Ling Ku. Ling Ku is what Dr. Tan calls it. Ling Gu is more of a Dr. Tong style, but remember they're kind of similar, just different interpretations. And Ling Ku is in the depression of the hand, and we're going to needle this in class so we know exactly where it is, and I'll describe it. I described it here, but I'll describe it a little bit more in class. I have a little box here talking about the successful treatment formula for lateral condylitis. So this is something that you'll see a lot of, and this is a treatment approach that I tend to use that works more times than not. If it's not working, there's some exacerbating factor involved, and typically that exacerbating factor usually is a cervical problem or some other type of referred pain. So you do want to screen the neck and do your Sperling A and B test to make sure it's not referring to the elbow, because I've had a patient where she had kind of both. She had cervical radiculopathy along with an epicondylitis, and I treated the epicondylitis. The condition seemed to get better, but didn't quite resolve. And it turned out later that it was more of a nerve root referral that was coming down to the top of her arm or her elbow. And so she didn't feel it at the epicondyle so much, but she felt pain in the extensor tendon. And so still treating it as though it was an epicondylitis, I had to change that and really focus on the neck in order to get the pain to go away. In this picture, and certainly in your notes, it describes a lot more of the innervation zones of the muscles here. And I like to treat extensor digitorum, and I'll show you a cool way to determine if you're in that muscle. But also extensor carpi radialis brevis is something that's shown in the literature a lot to be one of the culprits of this condition. But I've read more stuff that says it's more extensor digitorum. So, hey, cover our bases, treat both, be safe. We'll then do a zone treatment, which I think we have covered at some point during triple warmer 5, and then some other points there, and some 29 kinesio tape can really finish off this condition. Medial epicondylitis is kind of the same thing, often referred to as golfer's elbow, but just like tennis, you can get tennis elbow while golfing. It doesn't really matter what you're doing. It's just a slang way to talk about what it is. Now, the difference between lateral and medial epicondylitis is that lateral epicondylitis responds much better than medial. And some of the thinking is that the extensor tendons attached to the epicondyle in a fan shape, whereas the flexor tendons attached to the medial epicondyle, they're more tubular. They more have a sheath to them. And so when there's injury there, it tends to be a lot harder to fix or heal over time. You can still do localized osteoacupuncture, and I gave you some information in there as to other stuff that you can do, but it takes a little longer to heal. What you also want to involve is the pronator teres innervation zone, which if you look at your chart, you'll find that this innervation zone is over a very narrow area. And you have to be careful not to insert the needle too far, because the nerve is probably lying right underneath that innervation zone. So when the nerve is coming out, it's almost coming out sagittally. You know, if I'm looking at my arm, it's coming out straight. So when you needle in, you just create a sensation and stop right there. I would also needle things like the flexor carpi radialis. You can needle the palmaris longus. Just the musculature that goes up and attaches to this medial epicondyle. And this is just another picture of the medial epicondyle showing how the flexor tendons will come up. Here's the innervation zones. You can see them here. Very narrow in terms of, on the pronator side, it's just very small spots. And don't forget, pronator teres is a superficial muscle. And we'll talk a little bit about the anatomy in class. Let's get into wrist and hand pathology. Tenosynovitis or de Quervain's disease. This is when we use the Finkelstein test to determine if this condition is present. This condition often will sometimes get you confused between arthritis in the thumb joint, or is it tenosynovitis? And sometimes it matters in terms of prognosis, but our treatment approach tends to be relatively the same. Usually large intestine 5 will be used in some way. And this condition here, tenosynovitis, is an inflammation of the sheath of these two muscles. And excuse me, I gave you a lot of different points of what you can use to treat it, but adductor pollicis longus and extensor pollicis brevis are the two muscles that tend to be, or the sheaths tend to be involved. Now, extensor pollicis longus, if you make the anatomical snuff box, is the one that kind of comes across here. Now, that's not the one that's being affected. It's this one here, this popping out tendon, and then you can't really see it, but there's one hiding underneath it here. So it's those two tendons, not this one that pops out. And the way you can needle these, because these muscles kind of come across the arm, is that triple warmer 5 and triple warmer 8 tend to be good areas to needle. And I have here cross-fiber these muscles by palpating the triple warmer meridian between 6 and 8, and then you'll find tenderness sort of on the dorsal side of the wrist. Another thing you can try, which I sometimes do, is I needle. This picture is showing, of course, I realize now it's a white line, but are these along the muscles or along the sheath without penetrating the sheath. In this particular case, if the sheath is already irritated, in this particular case, I don't want to irritate it further. So I can put needles alongside it in the skin, maybe run electrical stim there, but I don't want to touch this tendon. I don't want to touch this sheath of the tendon either. All right, the granddaddy of wrist problems is carpal tunnel syndrome. That's a decent picture. Let me show you another. Here's what's happening. The carpal tunnel is narrowing for, some don't understand why it narrows. Others have suggestions as to why it might narrow. But under the flexor retinaculum here in the wrist, the nerve is getting impinged. And sometimes it's from the inflammation of the nerve sheaths of the flexor tendons that'll cause it, that'll pinch the nerves. But the way it's going to present is with numbness and tingling along the thumb, index, middle, and then the the lateral portion of the ring finger. So you can see in this picture to my right, old picture, oldie but goodie, because if you've done the hand dissection or you've done the cadaver dissection recently, the nerves really do kind of branch out and run down the fingers on either side. So when I'm talking about median nerve problems, it's going to affect these particular fingers. If I'm talking about ulnar nerve problems, maybe the cubital tunnel syndrome, the way that's going to be affected is going to come down the medial side of the ring finger and then affect the pinky finger. So one thing I wanted just to mention before we go on is if I have my pinky and my ring finger on numb and tingling, where's the problem occurring from? I would have to first start at the neck to rule out that it wasn't a C8 nerve root impingement by doing my Sperling tests. And then I can come down into the shoulder and do testing, but I can come down to the elbow and do the elbow flexion test to see if it's coming from the cubital tunnel. I have to differentiate, because am I going to treat the neck or am I going to treat the elbow? Or am I sometimes going to treat the wrist, because we can also get an entrapment up here at the wrist. I can do all three if I'm not really sure, but I like to know a little bit where the pathology lies. I've had bad stories of patients, actually a story from what a physical therapist told me of someone going in for surgery for carpal tunnel syndrome, and ultimately after multiple surgeries on various parts of her body, it was a cervical radiculopathy. So, not good. With median nerve entrapment in carpal tunnel syndrome, this is when you can get that thenar wasting. And we talked a little about that before. So not only was there a sensory issue, they got motor loss as well. Let's see here. You want to rule out in carpal tunnel syndrome, of course, pronator teres syndrome. Is it coming from the wrist or is it coming from the pronator teres? You need to be able to know where it's coming from, where the impingement is coming from. Ping Chan was a teacher of mine, traditional bone setter, practices down in Quincy area. And he often would say, palpate C2, C7 area until you find an archure spot, and usually between C4 and 6. And since we know C5 and 6 is often an area where there's degeneration or problems, then we would palpate there maybe to see if there's any sensitivity. I tend not to palpate. I do the orthopedic test to see what's going on, because, you know, poking all over the body can sometimes be very time consuming and kind of leads you off track a little bit. He also recommends small intestine 11 as being very important in carpal tunnel syndrome, not necessarily meridian-wise, but because the point can relieve a lot of stagnation in the upper extremity. And he also would mention treating the shoulder, elbow, wrist, and neck would be better than treating the wrist alone. And this is true. You wouldn't want to treat just the wrist for carpal tunnel syndrome. You'd want to involve some Wato-Jaji points that affect the C6, C7 nerve roots. So remember that. You want to be able to differentiate between whether it's a wrist problem, an elbow problem, a shoulder problem, which we didn't talk about the thoracic as much, or is it coming from the neck? Here's just a picture to show, again, C6, C7, C8. I'm not crazy about this picture because it doesn't show C6 as being the index finger. So this is netter. So just, find a picture you like. I like the one that includes the index finger for C6, and C7 tends to be more middle finger, but it actually has some overlap between 6 and 8. So what Jaji points to be used, of course, you want to use the C6, C7, C8, more C6, C7 than C8. If you had an ulnar nerve issue, then you'd probably use between the space of C7, T1 for the C8 nerve root. This is the solution usually for carpal tunnel syndrome. Cut the retinaculum, make space. Above me here is the scar that tends to be formed in a patient who has carpal tunnel syndrome. I had a woman who had 2 surgeries on one wrist, 3 on the other, because every time she would still be developing carpal tunnel syndrome. They kept doing a surgery, and she still had problems. So you can imagine after one surgery the amount of scarring that occurs in the hand. And if you've done the cadaver dissection, you realize there's really not a lot of room for scarring in the wrist and hand. It can create a lot of problems there. All right, let's get into ganglion cyst. I didn't put it in your notes, but it's something you're going to see in practice. There's a difference sometimes between what exactly is a ganglion cyst. Sometimes there's a synovium irritation in the joints, but other times it's just like a little pocket of synovium forms and creates this bubble. And so sometimes when you palpate someone's pulse, you'll find a bump there, and if it's not osteoarthritis, it's probably a ganglion cyst. And sometimes patients don't even know they have them. What it usually is, it becomes unsightly. It's only a problem if it's pinching a nerve. Even today, if you say, how do you treat a ganglion cyst? The idea was to hit it with a big book or a Bible, to pop it. And, you can do that. It may just come back afterwards and it hurts like hell. Sometimes, way you can treat it, I like to do a little bit of thread moxa around the cyst itself. But more often than not, it's not a problem for the patient. They just don't like the way it looks. And they'll sometimes go to the doctor and get it drained, which, again, you're going to drain it. What's going to happen? It's going to come back. It's a synovial outcropping. It's just going to come back if it's a problem. But they only tend to treat it or pierce it when it's causing other types of issues like pain or nerve entrapment. They don't want to pierce this thing because just like a bursitis, you're creating a vector for germs to get in, and that can cause an infection. In this particular one, they're removing the sac itself. So I haven't really heard of anyone doing that nowadays. I guess it could be a surgical option, but I would just think it's just very better to pop it and maybe remove it a different way. I don't know. Finger treatments, I flashed a picture here because it's an awful picture of someone who lost their finger, just attaching it together. What you don't see when you see this picture too is if you look at not that bad injured finger, but the one below it, it's got a pin going through the tip of the finger to probably pin it to the next joint, because it looks like the whatever cut this guy's or this woman's finger didn't stop there and took the other one too, and that one was already repaired. All right. So lots of types of finger issues that we don't usually get time to get into. The most common one you'll see is trigger finger, which is a sort of a swelling or a nodule that forms on one of the flexor tendons, and that gets stuck under the slips of the finger. So they'll make a fist, and then when they go to open their hand again, it gets stuck, and they have to manually open it. I know some patients who will have pain from that because it gets stuck and just the little nodule rubbing up against the slips underneath, that causes pain. So just something to be aware of, and if you have some questions about that, you can ask them. We'll go over it in class. This is a picture, I don't know why I'm putting this up here, but of someone who got too much cupping. So everything in moderation. I just thought it was interesting. It's probably just done by someone who thought, if I move all this chi, it might be a good idea. I mean, I can't imagine this being a good idea, but and then here are some finger monkeys, my favorite picture of cuteness, which are these little monkeys. So thanks for watching, and I'll see you in class.